Good morning, everybody. I'm so happy to be here. I have a special place in my heart for Nashville. I attended Meharry for medical school, and medical school was really hard, but I loved my time in Nashville. I'm, again, just grateful to be here with you all today. Perinatal quality collaboratives across the country are so important for moving the needle on maternal and infant outcomes. But as important as we are as collaboratives, it is you all that are boots on the ground doing the work every day. And so today I want to give you what I think are some quality improvement tools for success. And so I give you my experience leading our perinatal quality collaborative, but even before we had a perinatal quality collaborative, being the person that was at the hospital and at the health system trying to implement change. And so again, these are just lessons learned and tools for success. So we're going to talk about what quality and quality improvement is, talk about how we effectively lead change, discuss the role of perinatal quality collaboratives, and then we're going to talk about how to identify and manage resistance. Y'all, change is hard, so we're going to talk about that. So when we talk about quality, so this is the definition for the Institute of Medicine. Quality is the degree to which health services for individuals and populations increase the likelihood of desired health outcomes and are consistent with current and professional knowledge. So basically, it is us implementing evidence-based practices to make sure that all people have desired health outcomes. And quality improvement is the framework for systematically making changes to improve care. So this is all about change when we're trying to do quality improvement. So this is an audience participation, so I need y'all to talk back to me. So how does change make us feel? When somebody asks you to change, how does it make you feel? Oh, y'all are good. Everybody's talking at the same time. Nervous. Okay, what else? Yell it out. Frustrated, okay? Anxious, uncomfortable, confused. Okay. Optimistic. Thank you. I was looking for somebody to give me something positive, so that's great. Excited, exactly. So when somebody asks us to change, I don't care what you're trying to change, but anything, you can feel fearful, sometimes anxious. You can feel uncertain. How many things are you asking me to change? Nervous, unsure, challenged. I just told you that something you're doing is not right, and now we got to do it a different way. That makes people feel challenged. It can be stressful, and people also become very defensive. So why does this emotional response happen? So this is the Kubler-Ross change curve. So as you are asking somebody to change, these are all the emotional responses that happen. So there's shock, then there's denial, then there's frustration, then there's a little bit of depression, then they start to experiment with that change, they make the decision to change, and then they integrate it. But all of this emotional response happens, and I think that we, especially those of us that do quality improvement, don't think about that emotional part. And then you'll see this is the change management Lewin curve, and you can put this on top of those emotional responses. You're asking somebody to go from the status quo. So for example, when I went before my partners and I thought they were my friends, they did not treat me like friends, and I told them at my hospital we were going to do quantification of blood loss. I realize now I'm telling that doctor that's been practicing for the last 30 years, I know you've been estimating blood loss for the last 30 years, but that's all wrong. And so now we're asking them to unfreeze something that they're doing and go to something different. And so these are the emotions through that change process. So when you start to have resistance when you ask somebody to change, you have to understand that's a necessary component of change. I know for me, again, early in my career, when I was leading change and quality improvement and people started to resist, I thought it was because I did something wrong. I thought it was because I didn't educate enough or I didn't plan enough. Now, resistance is part of change, so there will be some, but if you do not get that resistance under control, it will completely disrupt your project or whatever you're trying to initiate. And so again, this resistance represents fear, challenges to level of comfort, challenges to pride, and then the anxiety of the unknown. So we're going to watch a small clip about change and about resistance.
As far as policies go, some of the things I thought that would make the company better is something as simple as uniforms.
What is this crap here?
Some awesome new uniforms.
This is not a beauty contest.
I thought the guys would like it. Well, I had another thing coming.
I knew this was a bunch of crap.
The only way that I would wear that if I was dead.
You done lost your mind.
For some reason, things that match and nice pressed pants, no, that was out.
I'm not doing it. I'll tell you that right now.
I ain't asking permission.
We make
Uniforms.
duck calls. Quack, quack.
Quack,
Put
quack.
your uniforms on, boys.
I don't know what happened. Willie, he either had a nightmare or something at home. We had to wear a stupid uniform.
I cannot believe y'all put those uniforms on. This is ridiculous.
Jace, he got hard-headed. He said, I'm not wearing the uniform.
Jace, go get your uniform.
I am not wearing a uniform, ever.
All right, I'm docking your pay.
All right, dock my pay.
I find the whole idea of having company policies ridiculous.
So we can see what happens when we have a change and we don't plan well. We can see what the response is. So we'll use that as an example as we go through our presentation today. So leading change. So we're going to talk about just leading change in general and how you plan your change so that you can manage your resistance. So whatever process that you're using to make a change, there's always going to be a general change process approach. So phase one is understanding the need for change. This is when you're enlisting your team, you're developing your vision, your strategy. Phase two is creating that sense of urgency. Why do we need to change? This is when you're communicating that vision often. You're empowering others to act on the vision, and then you're celebrating those small wins. I think that's the part that we forget to do quite often is when we're implementing change, we have this big goal we're trying to get to, and we don't celebrate those small wins along the way, which is very important. And then phase three is when we come into sustainability. So we'll go through each of these. So here's a general process for that phase one. You want to make sure you're defining the change, building your team, assessing the climate for change, determining your change approach, and then planning for resistance. And we'll go through each of these. So when you define your change, this is when you want to make your vision very clear. So your vision needs to be brief, it needs to be clear, flexible but strong, challenging, future-oriented, and it has the ability to inspire. So we saw in the Duck Dynasty initiative, did he say why they were going to make this change? He just came in and said, guess what? We're going to wear uniforms. So when we come into the hospital setting and we say, guess what? We're going to start doing timely treatment of hypertension. And we didn't say why we're going to do it, what the purpose of doing it is. We've not made that vision clear. So think about when you are, again, initiating a change and you're starting to enlist people, you want to make sure your vision is very clear. Not exactly what you're trying to change, but why you want to make that change. And it needs to be clear and it needs to be brief because you need other people to be your megaphone when you're not there. And so people need to be able to say that. Then you want to build your improvement team. So this is a mnemonic from a change management strategy called CAST. So you want to have a champion, you want to have an agent, you want to have a sponsor, and you want to think about your targets. So this is your improvement team. Your champion is the person that really believes in the change, but they may not have any authority. So for example, if you're trying to reduce your NTSB C-section rate, your champion may be a midwife. Your midwife may really believe in this change and knows that this is better, but she has no authority to make your physician say they're not going to do a C-section. But she is the person that will be your rah-rah person, and you need that rah-rah person because, again, change is hard. Your agent is the boots on the ground person that's actually leading the change. Your sponsor, and we're going to spend a little time on the sponsor, is that person that has the authority to express, model, and reinforce the change. This is the person that creates the accountability. Quite often I hear from our hospitals, well, we just can't get the physicians involved. That's because you don't have a sponsor that is on your team that is creating that accountability for the physicians. And then the target is anybody that the change is happening to. So it could be your bedside nurse, it could be a physician, it could be a patient. We tend, and it's great to hear that you all have patient partners. We tend to forget about having patients as part of the quality improvement team. Ultimately, this change is going to affect them. And so we need to hear their voice. Their voice needs to be a part of that design of your quality improvement initiative. So that sponsor, again, this is the person that can express the change, they can model it, they can reinforce it, and there's data that shows that 10% of your success is going to be based on what your sponsor expresses, 20 to 30% will be what they do, 50 to 60% will be what they reinforce. So again, going back to my example of when I was leading quantification of blood loss in our hospital. This is back in like 2015 before we had, like I said, PQC. And I was in my provider meeting, and I thought they were going to throw eggs and tomatoes at me when I told them that we were going to start doing quantification of blood loss. My chair at the time said, everybody, calm down. We're going to do this. This is what's being recommended nationally. We have a great process. This is what we need to do. Now, behind closed doors, he was like, I don't understand this. I don't understand why we can't just estimate blood loss. I think estimation is fine. That's fine. You can say whatever you want to say behind the doors, but in front of everybody else, I need you to show that you are doing this. And when you're in a C-section, I need you to have the nurses quantify. And so he did that, and so that really did help our initiative to move forward. And then the sponsor is really important for making sure you don't have normalization of deviation. Does everybody know do y'all know what that is? Okay, so we'll use another example, another real life example. We know that we're not supposed to electively induce any patients before 39 weeks, right? Okay. But you have that one provider that says, well, I'm just going to bring them in at 38 and 6, and we're just going to go ahead and start putting a little side attack. I mean, they're not going to deliver until 39 weeks, so, we're still going to be a 39-week induction. No, ma'am, no, sir. We still have now done something that might make them deliver before 38 and 6. But if you don't have somebody that is now creating that accountability and saying, no, we can't do that, now you're having normalization of deviance. And so those are little rips in your initiative that will then throw the whole thing off. So how do you engage your sponsor, right? Your sponsor may not really know anything about the activity, but that's the person that has the accountability. Be specific with your requests. Sponsors are usually very busy. They don't have time to have a whole conversation about this, right? Just like we were talking about, they need the Cliff Notes, the chat GPT version. So be specific about your requests. Be prepared with evidence to support your request. They need to understand, why are we making this change? How much is it going to cost? You have to anticipate obstacles and have solutions for those. Offer reasonable time frames to address concerns, and then set a reasonable time frame for executive decisions. Because again, this sponsor is important for making sure you have that accountability. So sometimes you again have to coach your sponsor up. This is a strategy that sponsors can use. I've had to use this. Actually, Don and I had a conversation last night. As a healthcare leader, I've had to use this little triangle before. So again, sometimes we're having to help our sponsors understand how we need them to help us. So this is the role of the sponsor and a reinforcement strategy that they can use. So when you start to see that person that is bringing in the person at 38 and 6 and giving them a little side attack, you have a cup of coffee. So I just noticed that we had this situation. I'm just making you aware. And so it's again creating awareness. If they continue to do that action, then you go all the way up to disciplinary change. And so performance improvement plans. And so you have to make sure that your sponsor is putting these things into place, because again, if you have one person that is starting to resist to the point that they're not doing your initiative, then it creates rips in your initiative and the whole thing will fall apart. So moving on, so assessing the climate for change. So we have to determine when we're going to be initiating a change. Are we ready to make this change? So there's 3 components to that. It's all subjective, but we're looking at capacity readiness. Do we have the people that we need? Are we culturally ready? Do we have what we need to make change? And are we committed? Now, sometimes we may not be ready on all of these fronts, but we have to make the change because legislation said we had to make the change, because we have CMS that says this is something we have to admit, these commitments of not commitments, COPs that we have to put into place. And so if that's the case, then we need to figure out how do we get our place ready for change. Now, of all of those C's that we just mentioned, I think the culture readiness is the most important. If you don't have your culture in place, it will eat your strategy for lunch. So all these things that I'm talking about, of having your team and having all those things in place, if the culture is not ready for change, then all of those things fall flat. And there's data that shows 70% of organizational change fails because we underestimate the level of resistance, the pace of change is too fast, or people feel like the change is forced on them. So again, we have to consider that culture part, and how do we change that? So there's 4 E's to get to kind of assess and kind of move the culture towards change. So it's a change management strategy called the 4 E's. And so that's engage, educate, execute, and evaluate. And we'll focus on the engagement part because I do think that is the part that is one of the most important parts, but also one of the parts that's very difficult to do. So why is engagement important? So when people are engaged, they feel that they are meaningful and that this is a meaningful purpose. They feel like they're able to contribute to whatever that change is. They feel like they can use their skill. They start to monitor their own activities, so you don't need the sponsor as much because they are motivated to make this change happen. And then they adjust as necessary. So again, that engagement is really, really important. So when we think about engagement, people are engaged intrinsically and extrinsically. And so the place we want people to be is in that top right corner where they're intrinsically motivated and extrinsically motivated. Now, you can't do anything about anybody's intrinsic motivation. I am Pollyanna, and I believe that all of us that came into public health and came into healthcare are intrinsically motivated because, y'all, healthcare is hard, and it's really hard right now. So this is, there's other things that you can be doing. So I believe that all of us already have that box checked. So then how do we extrinsically motivate people? I have found, people like to eat. Cookies, pizza, donuts, that's a great extrinsic motivation. I'm going to talk about, when I get to sustainability, I'm going to talk about one that we have done on the LAPQC side to help with sustainability as an extrinsic motivation. But think about that. If you are constantly asking people to do stuff, and they are intrinsically motivated, but you're not giving them anything, you're not celebrating those small wins, they are going to be frustrated. So you want to make sure that you are building that in. I won't spend time on this just in the interest of time. These are just different models for change approach. The TRIP model, Plan, Do, Study, Act is the one I think most people have heard about. It's the one that I've always used. It's the one that we use for the Louisiana Perinatal Quality Collaborative. But there's also DMAIC, if anybody has done green belt, yellow belt, that's the strategy that they use, and then Cotter's. And so moving on to phase 2. So now we've planned everything out. Now we're ready to get everybody involved. We're getting ready to launch. This is when we have to communicate the change. Again, this is why it's so important for that vision to be brief. In Duck Dynasty, how did they communicate the change? They really didn't communicate the change. He just came in and said, we are wearing uniforms. We're going to start wearing uniforms. He didn't say why the change was needed. He didn't say why they needed to start wearing uniforms now. He didn't say, is this going to be like we're changing our tops, we're changing everything, we're going to have a different uniform every day. He didn't say the full extent of that change. And you heard the other people on the team saying this, what's gonna improve? We make duck calls. Like, how is that going to help our business if we have on uniforms? So you have to make sure that in your vision you are saying that part. And I want to emphasize that because all of us that are in the weeds, we see why we're making this change. We understand why it's going to improve things, but the other people you're asking to change may not. So you want to make sure that's included in, and then how will we measure that change? The other thing you have to think about when you're building the communication plan is Different people communicate differently, especially by our provider types. The way you communicate for a doctor is going to be very different than how you communicate for a nurse. Is going to be very different for how you communicate for an executive. So for example, if we're talking about going back to QBL and doing quantification of blood loss, an attending physician may need to understand, well, what are we doing? What is this? The goal is to improve quicker treatment of acute blood loss. When are we going to communicate this? Well, we need to communicate pre-launch so that everybody knows what's coming on. Monthly, we need to give information at provider meetings. Quarterly, we need to see some data of how this is improving. Nurses may be a little bit different. What needs to be communicated to them is, well, what is the thing that we're doing? Because they are the ones that are actually implementing the change. So what needs to be communicated is a little bit different. So it's the details of the process. Timing and how may be different as well. I know in my hospital, they communicate everything through a Teams chat. Everything is a group meet or a Teams chat. We don't do that as well, at least in my hospital, physicians don't do that. That's not how we communicate. So you have to think about your communication tool as well. This goes back to the vision, but you have to think about an elevator pitch. If you're communicating to that executive, you may or may not get time to actually be in a meeting to communicate with those executive teams or that executive or the team. So you need to have an elevator pitch. Who you are, what your team does, what problem are they solving, why you're the best at it, and what you need from them. So again, thinking about that quick communication. So where do PQCs come into this? So again, statewide perinatal quality collaboratives. We use collaborative learning, rapid response to data, and quality improvement science to improve population health. The data part, who likes submitting data? Nobody? Okay, yeah. So same in Louisiana. Nobody likes to submit data. It's hard to do, but it's so important. I'm going to tell you why in a minute, but it's so essential to the quality improvement process. And that's in that Plan, Do, Study, Act. So when I say improvement science, a lot of times I get this question, well, what is improvement science? What does that even mean? And so it really is these 6 things. It's systems thinking about how do we change the system. So not this one thing, but how do we change the system so that things are improved? It's that data-driven decision. Again, I'm going to tell you again in a second when we talk about data why that's important, but we need to use our data to tell us how we need to move. Patient-centered care, making sure that we're keeping patients at the center of that change. That's why it's important to have patients on that quality improvement team. It's important to have patients as part of the data part as well, not just the data that we think about of what was our what's the severe maternal morbidity rate, but what is that qualitative data that we're also getting back from patients for feedback. And then this iterative cycle. Change is not one change, it's a series of changes to get to that outcome. That team-based approach. So again, this goes into that collaborative learning and thinking about when we're leading quality improvement in our hospitals, it's not just what we are doing as physicians. It's not just what we're doing as nurses. It's not even what we're just doing as maternal health providers. It's also our anesthesiologists. It's also our ED physicians, our ED providers, our ED team. Sometimes it's also labs. Sometimes it's pathology. Sometimes it's blood bank. But thinking about that team-based approach. And then the last part is sustainability and spread, and we'll spend a little time talking about that. So the data piece. So why is the data so important? All improvement is change, but not all change is improvement. And so what we are not trying to do is throw spaghetti at the wall and figure out what sticks. The only way we're going to know if what we are changing is making things better is we have to have the data. And so that tells us if we're moving in the right direction. And so this comes from Dr. Berwick, who led the IHI for a long time. He says, to make improvements, we must be clear about what we are trying to accomplish, how we will know that a change has led to improvement, and what change we can make that will result in improvement. So again, that's back to that data piece. For those that are not in quality improvement, they don't always understand that change is a series of changes. So if we're talking about for example, one of the things that we're working on is postpartum blood pressure checks. So having a blood pressure symptom check for patients that have severe hypertension within 3 days of discharge from the hospital. So if you come to your providers and you say, this is what we're trying to do, they may not understand, or your nurses too, they may not understand, we're gonna put this one thing in. That may not solve the problem. You may try doing a flag on the chart to know that when your discharge nurse goes around, these patients need an appointment, okay? That's not gonna work for everybody, so that may work and you're gonna have to adjust. You have to set that anticipation up front when you are starting your initiative, that there are going to be a series of changes to get to the outcome that we're looking for. And then the final stage is the sustainability phase, which I think is one we don't always think about when we're planning our initiative, but you have to plan for sustainability at the beginning. So the sustainability of your initiative is going to depend on the foundation that you build. That's why I'm using the 3 little pigs. Because if your foundation is strong, then your sustainability is great. I think we've had many tests in our foundation, COVID-19. When we looked at our data, we were doing great with timely treatment of hypertension in Louisiana. COVID-19 happened and we fell all the way off. And we stopped doing timely treatment of hypertension. It was very, very telling. Hurricanes, tornadoes, we have many, many things that we can't control that will affect our quality improvement initiative. But what can't change is the improvement, because we still have mothers and babies that need the improvement to happen. And so if your foundation is strong, then you will still see your change happen despite these challenges that may be happening. And so you have to design for sustainability when you are designing your initiative. The other reason is a lot of times in healthcare, this is what we do, right? Squirrel. We're working over here on this one thing, and then this other thing pops up, it's in the news. Okay, now I think we need to change and we need to work on this. Or we have an external force that says we need to work on this. And so we have to make sure we're building in the sustainability, because the first thing that we worked on still needs to continue, and what we need to not do is go back into our old ways. And if you're not building in that sustainability to monitor, to measure, that's exactly what will happen is people will start going back into their old habits. So the way we've done this through the Louisiana Perinatal Quality Collaborative, I didn't, in the interest of time, I didn't put in all the initiatives that we're working on, which is much like you all are doing it in TIP QC. Our very first initiative was on hemorrhage and hypertension. Once we worked on that and for the time frame that we set, then we moved on to the NTSB C-section rate, then to obstetric sepsis. While we were working on obstetric sepsis, we then started working on also improving care for the substance-exposed dyad, so working on substance use disorder with mothers and babies. And we're also working on infant feeding, nutrition feeding through the gift. And we're working on caregiver perinatal depression screening in pediatric practices. And we're working on obstetric readiness in emergency departments. So there's a lot that's going on. And we all, quite honestly, have to have all of these things going on because we are in crisis mode with our maternal and infant outcomes. And there are a lot of things that we need to change. But what we can't have happen, again, is working on hemorrhage and hypertension, and now we start working on obstetric sepsis, and we stop looking at hypertension and hemorrhage. So one of the things that we did as a collaborative for that extrinsic motivation is we developed the Birth Ready designation. So it's a designation that we give to facilities that are showing consistent health care and quality improvement in their work. And it celebrates those improved outcomes as a result of implementing those practices that create safe, patient-centered, dignified birth. But it's also a way for us to make sure that we are creating that sustainability. So in our Birth Ready designation, we have 5 domains. We have participation in collaborative learning, and this is requiring the hospitals to attend collaborative calls, to attend our in-person meetings, patient partnership. So that is requiring our facilities to work on patient partnership. Right now, they all are required to have a patient partner on their hospital quality improvement team. But we've also worked on things around patient-centered care, around health equity, around getting that feedback from patients that leads to change. Policies and procedures, that's making sure, or having our hospitals to have policies and procedures related to the things that we've worked on in hemorrhage and hypertension. And quite honestly, a lot of the things that we do aligns also with what they have to do for national things like the communities of practice, commitments of practice for CMS, things that they're having to do for the Joint Commission. So in addition to them doing that for us, we are also helping them to get these things accomplished. Structure and measures, that's the data piece, and then outcome and process measures as well. And our hospitals have really enjoyed this designation. Now, we don't give any money, they don't pay. We didn't even get a logo until like a year ago. So we didn't have anything that was great that we were handing out. It was just the recognition, and they really appreciated that. Now, I will also say the first year that we did this, we did a press release because we're in the Department of Health, and so they like to do press releases. So we did a press release. That was picked up by USA Today. Once that happened, we never had so many CEOs of hospitals calling to say, well, how does my hospital get involved? Well, why aren't we on the list? Well, what do we need to do? Well, when's the next round of designations? So that extrinsic motivation, depending on how you position it, not only will motivate your sponsor at the hospital, but it then also motivates on the executive level so that you get the resources that you need to do your quality improvement. And again, it didn't cost us a thing. It didn't cost anything. So resistance, when you meet resistance, because you will meet resistance, again, we've talked about that's a necessary part of change. So the first thing you need to do is acknowledge the resistance. I don't like conflict. I want everybody to like me, so I am like, that resistance can stay over there in the corner, and I'm just going to pretend like it's not there. Well, that's not a good way to move, because let me tell you, when you're in a meeting or you're in any kind of place and that resistance starts, it is like putting blood in the water and the sharks start swimming. So now you're people that were kind of on the fence. They were not your early adopters, but they were like, okay, I think I might be able to make this change. Now you have that person that's putting out there all these reasons why it's not going to work and why we shouldn't be doing this. Now your people that you kind of had on board, they're like, wait a minute, maybe we don't need to do this. So you want to make sure that you are nipping that resistance in the bud. Part of that, and we've talked about this a little bit, is just understanding where the resistance is coming from. Again, the first emotional response is going to be resistance, but if we are past that first emotional response and it's continuing, we need to understand what's going on. So is it a lack of understanding of why the change is needed? Maybe you have not voiced your reasoning the best, or they don't understand your vision. Have they had past negative experiences with change where they've tried to change and they couldn't change, or they got in trouble because they didn't make the change? Do they have the resources that they need to change? Are they seeing this as an increased workload? That's a big one. If that's happening, you need to then think about how you are making that change. Or is it the fear of the unknown? So with those roots of resistance, you're going to have 3 things that you're going to have to really manage. Moving from the status quo, so that emotional change, surviving that emotional roller coaster of the change, and then understanding that individual's factors for why they are giving that response. And so as you're asking somebody to change, they're saying, well, what if I can't change? Well, what's in it for me when I do change? And we saw that in the Duck Dynasty. Well, what's going to happen if I wear these uniforms? What will I have to let go of? Again, you're moving from somebody's comfort zone, from the way they've been doing things for forever, to something else. And then what's up ahead? What other things are you going to be asking me to change? So the way that you manage that moving from the status quo is to prioritize the change. So this is a PIC diagram. This is one of those Lean Six Sigma tools. So when you are designing your initiative and you're thinking about change, because again, it's not one change, it's a series of changes. So you want to think about, well, which of these changes am I going to start with? And so you think about what's going to be easy to change and what's going to give you a low or a high payoff. And so you can put your changes into these categories. What you probably want to really start with is something that's easy and low. Like, for example, if you're implementing the postpartum hemorrhage bundle. At my hospital, again, when I started doing this is before I had gone to school and got a degree, and I was like, oh, this sounds so interesting. We're going to start with quantification of blood loss. That should not have been where I started. That was a challenge. It was a high payoff because now we are going to know better about blood loss, but it's also a very difficult change to make. We got to get new equipment. We have to figure out a new way to calculate the blood loss. So that was very, very hard. And so we didn't have any small wins. We probably should have started with just doing risk assessment. That was something that would be easy, and it's a high payoff. That was just a matter of creating a piece of paper. Now Epic has changed and has a whole risk assessment in the chart that makes it easy to do. But you want to think about that when you're making your changes so you can get those small wins early. With the addressing resistance and the emotional roller coaster. So you have to understand how that change is going to impact that individual, and that will explain that emotional response, making sure you're clarifying the expectations and helping them to understand that the emotions are normal. So when we are asking people to change, you are always dealing with the head and you're dealing with the heart, right? So if you're speaking to somebody's head and they still are giving you a lot of resistance, then that means they don't really understand. You've not made it clear what the vision is. If you're speaking to their heart and they're still not changing, that person is burned out. So if you're telling them, you know, that patient that you had that ended up going home and had a stroke, we are going to be doing this to make sure blood pressures are controlled. And they're still like, no, I don't want to do that. That's somebody that's burned out, and that needs to be addressed because that can lead to so many other issues. And so we want to make sure that we're directing the mind, but also motivating the heart. We have to make sure we're listening more than talking when you have that person that's being resistant. Asking them, how do you think your patients will benefit from this? And do you see anything that's going to stop us from being successful? So making sure that you're asking those open-ended questions so they give a chance. Sometimes people just want to vent. They just want to get it off their chest. They don't really want you to do anything. They just want to be able to express themselves and to speak their mind. So you give them the space and you give them the time to do that. Because if you don't, they're going to do it in the middle of your staff meeting, and then it's going to be a problem. And you won't be able to rein it in. Now, don't look at them right now in this room, but there is somebody that you can think of that no matter what, they are going to resist whatever you do. If you told them, you know what, I'm going to give you $1 million, they're going to tell you, oh my gosh, now I got to pay taxes. I'm going to have all these people calling me because they want to get a loan. That's just who they are. And you all know who that person is. And if they're at your table, don't turn around and look at them. But you all know who that is. That person, I call them a naysayer. That is the person that you want to get to do your pre-mortem analysis. So a pre-mortem analysis is looking at your initiative before you launch it to say, how can this go wrong? Again, I am Pollyanna. I am very logical. I think if A plus B equals C, then we just need to do A and B and we're going to get to C. And that is just not how life works. So I need naysayers around me to tell me where there are blind spots and to tell me why all these things are going to fail so that we can plan for that on the front end. So by getting that naysayer involved in that pre-mortem analysis, one, you've already understood where your blind spots are and you've already designed for that, but now your naysayer is your champion because now they're invested because they helped you co-design this initiative. So take-home messages. So all improvement is change, but not all change is improvement. Resistance is a normal response to change. So it doesn't mean that you've done something wrong because you start getting resistance, but you do need to design and you need to get that resistance and nip it in the bud. Be successful by planning your implementation. Plan so that you can manage resistance, but also plan for sustainability. Don't move too fast. Again, lessons learned, because I want things done yesterday. Don't move too fast because that will create more resistance, and then make sure you're planning for it. And then I am happy to answer any questions. This is my Instagram if anybody wants to follow me, and I'm also on LinkedIn.